for as much as novel therapeutics have improved responses and survival for patients with CLL or previously treated CLL, unfortunately, I feel like the needle hasn't moved very much for patients with Richter's, whose survival is markedly short compared to CLL, often less than a year. So where I hope research moves things is that we can get away from what really has been the standard for Richter's, which is chemoimmunotherapy, because so many patients either don't respond or they have brief responses and then progression. And so trials, importantly, or just the way we approach patients from the start, I think has evolved. Of course, many of us too won't just take a chemoimmunotherapy approach when patients have been exposed to novel agents such as BTK inhibitors. We'll at least keep that going or switch inhibitors and combine it with chemotherapy. But ultimately, to maintain the response, since we know that patients with Richter's that's related to their CLL will, even if in a good response, be likely to relapse. We're starting to see, for example, reports of using CAR T or cellular therapy for those patients or bispecific antibodies. So I really think as we understand that diversity for patients, most of them having high-risk mutations that aren't going to respond to chemotherapy or been exposed to novel drugs, that we'll start from the start approaching patients with a new diagnosis of Richter's differently and getting them to an agent or cellular therapy to try to maintain that response.